Buenas tardes, estamos llegando a nuestra última actividad de un día excitante y largo y tenemos como conferencia final la conferencia de la doctora Mehran. Es un honor para mí y un privilegio presentarla. Ella es Professor of Medicine in Cardiology and Population, Health Science and Policy, Mount Sinai Professor in Cardiovascular Clinical Research and Outcomes y Director of Interventional Cardiovascular Research and Clinical Trials en el Icahn School of Medicine of Mount Sinai. Ha publicado más de 1.100 artículos, 150 revisiones, ha sido coautora de 20 guías y ha sido citada en más de 55.000 documentos. Su conferencia se titula Terapia antiplaquetaria en el síndrome coronario agudo, lecciones aprendidas en 2021 y mirando hacia el futuro. Adelante, por favor.
It's really truly an honor. I'm here to talk about the evolving concepts in antithrombotic therapy. Let me just show you where we are on as far as my disclosures. Important for you to note all of them, specifically to the devices and drugs that we'll be talking about in terms of antiplatelet and antithrombotic regimens. Importantly, the Twilight study, which I led and was funded by AstraZeneca. The current antithrombotic regimens are tremendously diverse. You can start before the cath lab, in the cath lab, and then in the long term, both anticoagulants and antiplatelet agents. And we all know that the permutation and the differential of what you can do in the different clinical settings could be infinite in combinations. So how do you choose the best possible antithrombotic regimens for our patients remains to be a very important question for all of us. We use them as primary prevention. We think about those patients with subclinical atherosclerosis and put in a lot of the risk factors for primordial prevention, which is incredibly important. But that has been an area that has been under question, right? Over the last couple of years, we have seen that trials with aspirin haven't really come up with great results in primary prevention. In secondary prevention, however, I think we have those patients who have established coronary disease who undergo revascularization, where there's a tremendous need for these patients. So what I thought we would do today is talk about some of the controversial antithrombotic therapies and really how long do you continue DAPT for? How long do you continue the P2Y12 receptor blockade? And when you stop DAPT, do you go to a P2Y12 monotherapy or to aspirin? Should aspirin be dropped at any point, maybe earlier than what we've ever imagined? And then this really important balancing of the likelihood of preventing thrombosis with the risk of bleeding is something that's extremely difficult for us to actually get our arms around. We use risk scores, we do all kinds of things, and yet still we see there's a lot of overlapping risk between bleeding and ischemic events. And then that patient with atrial fibrillation, difficult patient to manage because they're at risk for stroke. And we know that there's been some results in dual antiplatelet therapies, but we also know that anticoagulants are superior. And so it becomes very, very difficult to manage those patients who have AFib, who undergo PCI, who require antithrombotic regimens. For how long? What do you do? I'll try to do all of that today in the lecture. And just in 20 minutes, I think I decided to talk about some of these aspirin-free strategies, de-escalation strategies, and atrial fibrillation with PCI. So let's begin with the aspirin-free strategies. Over the evolving 40 years of PCI, we have gone through the era of worrying about thrombosis to an area of worrying about bleeding, and now at the equipoise that we stand to balance bleeding and ischemic complications. And we've ridden the roller coaster of prolonging DAPT, shortening DAPT, de-escalating, going to a potent agent. And now that we are at a place where we have actually come to the best possible results we can get at the time of PCI with technology that has been fantastic using physiology, IVUS, as well as the best current generation drug-eluting stents that have shown fantastic safety and efficacy profiles. Where do we stand with antiplatelet therapy after PCI? Well, aspirin has always been sort of the cornerstone of dual antiplatelet therapy. We've never, way back when we first started looking at clopidogrel, there was the Capri trial, where actually it showed that clopidogrel was better, but it was really hard to get away from this meta-analysis of 17,000 patients, 16 randomized trials, that actually showed that major vascular events, coronary events, and strokes were reduced with aspirin. And there was increased major bleeding, but the price of the big major events were it was so much more important to preserve that benefit versus the risk of the bleeding that was seen. And so I think it was really, really important that that became sort of our cornerstone. But where are we today? Today, we're at a place where we have risk reduction strategies that have reduced that baseline risk of the patient. So the added benefit of aspirin is going to be minimized when you have PCSK9, ARNI, SGLT2 inhibitors. We have novel antithrombotic regimens now. These potent agents, direct oral anticoagulants, as well as the potent P2Y12 inhibitors, that makes the role of aspirin questionable. And what about the major bleeding risk that we have seen over and over again with aspirin, with a direct gastrotoxicity and an important GI bleeds that we have seen associated with aspirin, but also in combination with other antiplatelet and antithrombotic regimens, we've seen like severe bleeding events, intracranial hemorrhage. So we need to kind of think about that there are now uncertainties surrounding the use of aspirin for secondary prevention. And a lot of it has to do with some of the pharmacodynamic studies that have shown that when you withdraw aspirin in the presence of a potent agent, you really are not losing much in terms of platelet inhibition. You're still getting good platelet inhibition. The added benefit is really not seen. And then, of course, the P2Y12 receptor being the central role in platelet activation amplification, that interplay with other signaling pathway, including the GP2B3A receptor, makes us put back the P2Y12 mediated signaling as a pivotal role and establishing the efficacy of the P2Y12 inhibitors to reduce stent-related and maybe perhaps non-stent-related events. And as a result, we have seen now a lot of strategies where instead of dropping the P2Y12 receptor inhibitor, we're dropping the aspirin. And take a look. Here is the clopidogrel monotherapy story with STOP-DAPT investigators looking at clopidogrel alone after a month of dual antiplatelet therapy versus 12 months of DAPT, showing a reduction in net adverse clinical events in STOP-DAPT2 with design stent in the background, smart choice with 3 stent designs, showing after 3 months non-inferiority in terms of the major adverse clinical events and a reduction in bleeding again. When you go to clopidogrel monotherapy compared to DAPT, now again, this is an Asian patient population, but still very, very important understanding that you can go to a P2Y12 monotherapy, reduce bleeding, and now have no difference in your ischemic events. The global leaders investigators looked at a very, very important study, largest ever, 16,000 patients, where the ticagrelor alone strategy after 1 month of DAPT compared to all kinds of strategies in the DAPT for 12 months led to no difference in the all-cause death new Q-wave MIs at 2 years. This experimental strategy, actually, to me, this is a superiority when you show no difference in ischemic events. And in fact, it's a very, very good way to proceed. But this was a failed trial, a missed opportunity in my mind of how the investigators looked for superiority. And when you show no difference, do you really prove non-inferiority? You don't. That's an important thing to learn when you're doing these kinds of clinical trials, because even at 16,000 patients, we're still underpowered, depending on what margin, etc., for non-inferiority. And if you actually look at those adjudicated sub-study, when they looked at more endpoints of death, MI, stroke, TVR, they looked basically similar. No superiority, but the events were still trended lower with the ticagrelor monotherapy. Well, we took a different approach. In the Twilight study, and all of these other studies, they were open label. But here, we felt it was important to enroll patients after the patient is placed on ticagrelor and aspirin by the clinician, whether they were stable or unstable. And in those patients, after a 3-month observation period of aspirin and ticagrelor, if they had no severe ischemic events, BARC3B and more, or any kind of an ischemic death, of course, MI and major revascularization, if they met those criteria and they were compliant on their meds, they would be evaluated, and they were seen in person at the end of 3 months. And if they were and they agreed to be on this, they were assigned ticagrelor plus a study drug, which was aspirin, versus ticagrelor plus placebo, the study drug. The study drug became aspirin or placebo, matching placebo. No one knew what these patients received. 7,119 patients were randomized, and we had, our objective was to show superiority in reducing bleeding, which was a no-brainer. If you drop aspirin, you should reduce bleeding. So we went for superiority. We separated that the outcome, and non-inferiority in terms of death, MI, and CVA. So that's why we needed all those many patients. We followed these patients in like monthly or 3-month period, counting pills, evaluating them in person, making sure they had complete ascertainment of their events. And here's what we got. Here's the bleeding endpoint, BARC 2, 3, and 5. And of course, aspirin plus ticagrelor, 7.1%. With placebo, 4%. A reduction of 44% reduction of BARC 2, 3, and 5 bleeding. Statistically significant, primary endpoint met, numbers needed to treat only 33. If you look at BARC 3 and 5, we were even higher.
Y los números para tratar eran 33. Y si miramos BARC 3 y 5, incluso más altos, 55% de reducción del sangrado. Esto es el criterio de evaluación clave, de hecho. Pero es de secundario muy importante, porque mostraba no inferioridad en términos de muerte, infarto y stroke, en un protocolo en el que esto lo miramos como un criterio de evaluación de seguridad y muy importante. En el estudio Twilight, que se double-blind, placebo-controlled trial,
a TICO trial, which included STEMI and non-STEMI. We did not have STEMI patients in Twilight. 3,000 plus patients, really excellent follow-up. Randomization occurred at the time of PCI. 3 months aspirin and ticagrelor followed by ticagrelor monotherapy versus 12 months. In STEMI and non-STEMI, they showed a major reduction in bleeding, no difference in their ischemic events, and the MACE was positive in favor of ticagrelor monotherapy. If you put all of these studies together in this meta-analysis, which was published in Circulation, you see a reduction after PCI and after ACS in bleeding, and in fact, the trend towards improving major adverse cardiovascular events. And as a result, the 2020 ESC guidelines for management of non-ST segment elevation MI gave ticagrelor monotherapy in select patients a type 2A recommendation.
daban
And then came
antiplaquetaria,
ACC
monoterapia, una
2021,
recomendación
a
a
very
2.
important
Y
study
en
for chronic maintenance
2021, un
monotherapy
estudio
after PCI,
bastante
like a
importante para el
DAT
mantenimiento
study,
crónico en
but
monoterapia después de
instead of
PCI,
looking at
en vez de
they went
mirar
to single antiplatelet.
DAPT continuo, hicieron una terapia antiplaquetaria única de aspirina versus clopidogrel y esperaron 6 a 18 meses. Los pacientes elegibles fueron autorizados a aspirina versus clopidogrel y lo que encontraron fue encontrar una reducción del criterio de valoración primario, que era mortalidad de todas las causas, infarto miocardio no fatal, stroke, readmisión por síndrome coronario agudo, sangrado mayor, BARC 3 o más. El criterio de valoración estaba a favor de la monoterapia con clopidogrel. Los números que se necesitó tratar eran 51. Era un estudio importante, nuevamente mostrando que las estrategias sin aspirina pueden ser el camino a seguir en el futuro. ¿Qué pasa con las estrategias de desescalación? Hemos aprendido mucho, queremos reducir el sangrado, sabemos que los eventos son muy altos en los primeros 90 días y a partir de allí podemos disminuir, desescalar, pero incluso se podría desescalar antes. Y aquí está Tropical ACS, una terapia de desescalación guiada utilizando las pruebas de función plaquetaria, tomando los pacientes que tenían ACS positivo, con biomarcadores positivos, 1.600 de ellos, y le dábamos 14 días de prasugrel en el brazo de control versus terapia guiada con 7 días de prasugrel, 7 días de clopidogrel. Se les hacía pruebas de función plaquetaria en los pacientes que tenían una reactividad plaquetaria elevada y los que recibieron prasugrel y los que no lo hicieron, y un estudio muy bonito. Ahora, ¿qué encontraron? Que la muerte cardiovascular, infarto miocárdico, stroke y sangrado obliar era un criterio de evaluación combinado y mostraron una inferioridad, pero no superioridad. Y tal vez incluso sea bueno, no inferioridad. Tal vez sea el camino a seguir. Y recibió una recomendación 2B por el hecho de que no tenía la potencia necesaria para esos criterios. ¿Y qué pasa con los estudios genéticos para 2 y 12? Aquí se compararon los pacientes para conocer las pruebas de genotipo versus y los portadores. ¿Y qué es lo que encontraron? Bueno, estuvieron a favor de no inferioridad y no necesitaban superioridad y se redujo el sangrado menor y mayor de plato y muy interesante, no cumplieron con el criterio de evaluación primaria ni la superioridad que estaban buscando. Y luego, en la base práctica de la desescalación de la terapia antiplaquetaria dual después de PCI en pacientes con ACS, se estudiaron casi 2.400 pacientes asignados de desescalación o al tratamiento convencional. Estos eran pacientes psiquiátricos y por supuesto aquí se encontró una reducción en el criterio de evaluación primario. Los resultados de seguridad estaban a favor, o sea que esto podría mostrar que esto es una posibilidad para desescalación. Y lo que es más importante de este estudio, y estoy tratando de comprenderlo, es en el TALUS, en el estudio TALUS-AMI, que se presentó en SC 2020. Aquí los pacientes recibieron aspirina durante 30 días y luego, si no tenían eventos adversos, recibían aspirina y clopidogrel, y aquí mostraron una reducción significativa del criterio de valoración de muerte, infarto, stroke y sangrado BARC a favor de la desescalado. Ahora, aquí, cuando uno está mirando la muerte, miocardio, stroke y sangrado BARC, bueno, por supuesto que realmente no están al mismo nivel, especialmente cuando uno pone esto, cuando uno compara los diferentes factores. Y obviamente este estudio no tenía la potencia. Ahora veamos qué pasa con la fibrilación auricular y PCI, un gran dilema para todos. Como yo dije antes, los anticoagulantes orales son superiores a la terapia antiplaquetaria dual en términos de la reducción de los ACVs en los pacientes con fibrilación auricular, pero DAPT es superior a los anticoagulantes orales en términos de los eventos adversos relacionados con PCI, especialmente los relacionados con los stents. Pero cuando uno combina, uno puede, necesitamos, ahora tenemos los anticoagulantes orales directos y que se sabe que hay una sinergia entre estos anticoagulantes orales y terapia antiplaquetaria, tales como se pueden imaginar, con el efecto antitrombino de los anticoagulantes orales, que podría tener una función antiplaquetaria importante, que permitiría dejar la aspirina. Aquí hay 4 ensayos mayores mirando todos los anticoagulantes orales directos, rivaroxaban, dabigatran, apixaban y y aquí ustedes ven que en términos generales reducen el sangrado sin cambios en los eventos isquémicos. Las estenosis de los stents son mínimos y si piensan en la trombosis del stent, realmente no necesita significación estadística. De manera que tal vez se podría suspender la aspirina enseguida. O sea, ¿cómo lo hacemos? Bueno, aquí está el consenso norteamericano que se acaba de publicar en Circulation en 2021. Lo que decimos es la estrategia por defecto en los tratamientos periprocedimiento es anticoagulante con DAPT tan temprano como sea posible. Pero en pacientes con alto riesgo trombótico, uno puede hacer la triple terapia durante un mes y luego terapia dual y luego anticoagulantes orales. Miren ustedes, anticoagulantes orales más allá de 12 meses en pacientes con bajo riesgo de sangrado y de isquemia, uno puede ir lo antes posible a este tipo de terapia durante 6 meses con anticoagulantes orales. O sea que ven ustedes que el mensaje aquí es evaluar el riesgo trombótico y de sangrado en estos pacientes. Y si tienen un alto riesgo trombótico y bajo de sangrado, pueden tratar con ATP y escalar hasta... Y si ustedes tienen un paciente con alto riesgo de sangrado, estos son los pacientes difíciles, hay que pensar en la desescalación y necesitan pensar en un inhibidor de P2 y 12 en monoterapia. Y cuando ustedes tienen ese riesgo de sangrado alto y bajo riesgo de BARC, se desescala con corta duración más antes y uno puede ir directamente, yo les recomiendo ver las guías, priorizar el cumplimiento de los pacientes y realmente ver el riesgo de sangrado.
Por esta excelentísima
conferencia, ha sido fantástico.
Y con esta conferencia damos por terminado nuestro segundo día de congreso y los esperamos mañana con mucha más actividad e información.